Well, hello, medical science explorers. Отец Vladimir is here. And today we're going to discuss Mercury and retrograde. Just kidding. Now, the topic of our discussion is gestational diabetes. This topic was inspired by my mentor, Dr. Hobbs, who is an OBGYN in Augusta, Georgia. And without further ado, let's begin. When I'm talking about gestational diabetes, what comes in your mind? Let's say, if I have diabetes and I got pregnant and I have high sugars, does it mean I have gestational diabetes? Well, it's not a tricky question. If I'm asking you in the way I'm asking you, then you should say no. No, obviously. In this case, if you had diabetes and you become pregnant, it's not gestational diabetes. It's just diabetic who got pregnant. Kudos to Dr. Golian for this joke. All right. Well, when we're talking about gestational diabetes, we're talking about impaired glucose tolerance. And there is not much difference when you're starting the statement like that, when you compare it to a regular diabetes mellitus. But what's important is that it develops first time during pregnancy, meaning you had euglycemic patient who had normal blood sugars prior to conception. But then during your testing, you determine that your patient has impaired glucose tolerance. Well, in that case, we are talking about gestational diabetes. You can't explain it or phrase it better than Robbins and Catron, which describe this with a romantic statement. Pregnancy is diabetogenic state in which the prevailing hormonal milieu favors insulin resistance. You can see how deep this statement is, and let's try to appreciate the depthness of it. Depth. Well, pregnancy is diabetogenic. Yeah, it is. And if you notice, they say diabetogenic in quotations, because in reality, the way in nature, the way the evolution created the human, is that it is important that that the pregnant woman does not have a regular carbohydrate metabolism, because in a normal physiology, a woman or a man consume carbohydrates and should be able to bring them into the cell, right? So that our cells can benefit from it. But when we're talking about pregnant woman, in that case, we can't continue being selfish in that regard. We have to share that sugar. And the only way you would be able to deliver and efficiently deliver that sugar to a growing fetus if you have slight level of impaired glucose uptake by your cells. That way, you have high levels of sugar in your blood, and placental blood delivers that to the fetus so the fetus can consume it, right? And that's why Robbins and Catron describes this situation as prevailing hormonal milieu, right? Which hormones we're talking about? Well, we're talking about human placental lactogen, HPL, or formerly known as human somatomammotropin. I guess human somatomammotropin is a mouthful, so they decided to use you decided to use the term human placental lactogen, which, I think it's a great term because it tells you where is it coming from. It's produced by placenta, particularly by syncytial trophoblast, and it has numerous functions, but among one of them is to keep your sugars at the level that it's above normal, right? And there's also been suggested that cortisol and progesterone playing a part in that hormonal milieu, right? So we're talking about insulin resistance, meaning you produce your insulin, but at the same time, since you have this hormonal milieu where you have human placental lactogen, you have cortisol, you have progesterone, and they saying, hey, insulin, I know you like to bring glucose into the cell, right? But no, not this time. You gotta take it easy this time because we have a growing baby here. All right, baby needs some food. And that's the reason why human physiology evolve in the way it is. And notice I said physiology. I did not say pathology. Reason behind that is that in normal physiology, it is okay for a pregnant woman to have slightly higher glucose levels, right? But when those levels of glucose going beyond control, above and beyond, then we're getting to the problem, right? Because everything is good in moderation, almost everything, but in our case, hyperglycemia, high sugars are good in moderation. But when if it's going above, then we're having a problem, right? So that's what we're talking about. And remember, I mentioned that that if you were pregnant and become, if you had diabetes and become pregnant, it's just diabetic who got pregnant. Well, there is a term for it. There is a name for it. In medicine, everything should have a name for easier communication, and right. So sometimes we're calling it as pre-existing diabetes, right? Or some physicians like to call it pre-gestational diabetes, meaning patient was already diabetic, and then it's just having pregnant woman on top of that. Yeah, am I actually exacerbating it further? All right. And also you may hear they're using the term avert diabetes. From people whose English is not a first language, avert might sound a little confusing, at least to me. It sounded a little confusing, and because I was thinking avert, it sounds like something hidden, but not. Avert actually means obvious. You can see it as obvious. So, or antonymous term to it is covered. Now, you know the word cover, right? Cover something, right? Cover, cover. So that's a cover. And then you have kind of uncover, avert. So it's not covered, it's avert diabetes, meaning it's known. So we're talking about avert diabetes. And if you like to know, there is an interesting etiology, or I should say etymology of the word diabetes. What's diabetes? Diabetes just means from Latin coming through. And that's why See, we have two terms that also come as diabetes. There is diabetes insipidus, there is diabetes mellitus. Well, interesting fact is that in the past, Greek doctors, healers, that's probably how they called them, they did not have sophisticated lab equipment where, aristocrates comes in and they're trying to check his sugar and like, hey, give me a finger stick. They didn't have finger sticks. What they had is they had a urine stick. Yes, the doctor would ask the patient to get a urine sample, and doctor, being a doctor, will take a cup and he will get the urine sample, right? And they will, that tastes sweet. I would say tastes like honey, and that's where the word mellitus comes from. Mellitus means honey. So I don't know, they didn't have much about physiology. They had some knowledge, but they didn't have enough understanding what's the pathophysiology behind it. So I guess they were thinking that there are some hives forming in a human body, meaning the blood passing through these hives, they're making the urine sweet. And then they will call that diabetes mellitus, coming through the honey. They were thinking that urine tasted sweet. They call it diabetes mellitus. And then in the situations when you had diabetes insipidus, insipid strainer, they were thinking, there are two types of diseases. One is a sweet urine, non-sweet urine, because both diabetes mellitus and insipidus are associated with polyuria, right? So that's how you distinguish them, that there is diabetes mellitus, diabetes insipidus, coming through the urine, coming through the strainer. Yeah, and now you know. And eventually they decided to, well, there's another term, gestational diabetes, right? Well, that's self-explanatory at this point, so I guess you will never forget. All right, let's go further. So what are the guidelines? Well, the guidelines pretty well known, right? Pregnant woman should be screened for gestational diabetes at 24 to 28 weeks of gestation. And you can start with glucose load test. You load the patient with sugar, literally, right? Which is, patient doesn't have to fast for this test. Just comes in, you give him 50 grams of glucose, and you check the blood glucose in 1 hour. That's your first step. And if the level is less than 130 or 140 milligrams per deciliter, then you say, oh, listen, you're good, right? There's no gestational diabetes. But if it's above 130 and 40, then I was like, listen, something's off. Something stinks in suburbia. We got to do a little extra digging. All right. So in that result, you're going to do oral glucose tolerance test. And there are two methods that you can use. One is the 100 milligram of glucose consuming 100 milligrams, or you can give, there's a typo here. It's not milligrams, it's 100 grams. All right, so reach out to the author, Dr. Fisher. So that's going to be the test. So you can do 3-hour test, or you can do 2-hour test. You choose. Yeah. You want to wait 3 hours? 3 hours, you do 100 gram of sugar. You want to wait 2 hours? You can do 75. If you have enough time, do 100. But the idea is similar, right? So the idea is this. So there's a criteria. So for the 3-hour glucose tolerance test, you check the fasting blood glucose, patient's fasting since midnight. Check the sugars. If it's you want it to be 95 and below, right? Then patient comes in and you give him 100-gram oral glucose. You check the sugar should be below 180, and then 155, then 140. So you get all those numbers. And if you have two abnormal, then you diagnose your patient with gestational diabetes. Straightforward. With the 2-hour 75-gram oral glucose tolerance test, you give 75 grams and you're checking sugar levels. All right, fasting again. It's well interesting that they have a different criteria here. I guess 95, 92, not far away. And then you check in 1 hour and then 2 hours, and you're looking at you want it to be below 180 after first hour and below 153 after the second hour. In that case, if you have one abnormal again or above, more than one normal, then you diagnose patient with gestational diabetes. And again, we have to reiterate, the patient should have normal blood glucose prior to conception, right? Meaning patient's never been diagnosed with diabetes mellitus. And now we're noticing the patient has poor glucose tolerance, right? So that's gonna be gestational diabetes. Yes, we're not living in a perfect world, and sometimes those can be overdiagnosed or misdiagnosed. And we will talk about correlation and corrections and stratifying this information later on. But just keep in mind, the patient should have normal glucose uptake prior being pregnant, right? And if you're really wondering at this point and you have strong suspicion, you can get hemoglobin A1C, right? Hemoglobin A1C will tell you what was the average blood sugar in the patient over the course of 3 months, right? Because the lifespan of the red blood cells is 3 months. Right? Therefore, glycosylated hemoglobin will tell you, that's like fingerprints. Glucose is like sugar coating your hemoglobin and left these fingerprints over. And you can tell, right? But again, it's only good for 90 days, right? And if we're looking at 24 weeks to 28 weeks screening for this criteria, then in that case, you're beyond. It's too late. You can't tell when did those sugars work. So unless you do hemoglobin A1C prior, right, it should be significantly less than 3 months. Then you might be able to tell if there was some issues with carbohydrate metabolism prior. All right, consequences of gestational diabetes. Surprisingly, in contrast to women with pregestational diabetes, women with true gestational diabetes are not at increased risk of having an infant with congenital malformations because the onset of disorder is after organogenesis, and they do not experience diabetes-related vasculopathy because of the short duration of the disorder. All right. When we're talking about diabetes mellitus, it's been an ongoing, it's so it takes time. It takes time for your blood vessels being affected. Meaning, if we're talking about organogenesis, all right, we have poor vascularization, poor plus intrauterine growth retardation. Yes, that will not be seen in gestational diabetes mellitus. Okay, and the reason being is, again, it takes time to progress to that level. Okay, which is a good part. At least gestational diabetes mellitus doesn't give you that. All right. In that case, cui bono? Cui bono doing this test? Who benefits from this test for glucose tolerance test? Pourquoi? Pourqué? Зачем? And why we make our pregnant women drink this nasty tasting glass of sugary syrup? Why? And is it because we want to develop aversion to sugar and pregnant women so they will adhere to a better diet? Doesn't work like that. Maybe initially they tried in that way, but the reason being is we want to know if patient actually has gestational diabetes mellitus, because there are problems with gestational diabetes. And here they are: macrosomia, fetal truncal asymmetry. Right? You have a big baby growing in the utero. As a result, sometimes we have to, elect to perform operative delivery. Either it is cesarean, right, or instrumental vaginal delivery, taking a poor baby with a big forceps, because we don't want that, because there are difficulties passing through a vaginal canal for a big baby. It's a known fact, and pushing the baby through a vaginal canal, you can have all sorts of problems like shoulder dystocia. And what comes with that? Well, you can have brachial plexus injuries, and can have permanent damage, paralysis of sort. You can have a fracture in the baby's upper extremity, like clavicular fractures, things like that. Even neonatal depression, baby's trying to come out and then it's stuck. You just give up. It's just doesn't fit, and you can't acquit, right? So this is one of the problems. And on top of that, we have preeclampsia, right? We have gestational hypertension. They've been associated with gestational diabetes mellitus. Polyhydramnios, it is more common in a patient with GDM. Why? We don't know why exactly, but most of the evidence suggests that since babies having too much of too elevated, the sugar levels are too elevated, as a result, you have a osmotic effect, and baby is just producing more amniotic fluid, because amniotic fluid, as we're all aware, is just baby's urine, right? Fetal urine. They pee in that little pool, and the more they pee, the more amniotic fluid they have, and they cause you polyhydramnios. Okay. And there is more to this why. We have more serious problems comes with GDM. We have stillbirth, right? We have increased levels of neonatal morbidity. And all of those can be found in uncontrolled gestational diabetes mellitus, and even in suboptimal controls of gestational diabetes those problems can present. When we're talking about suboptimal control, what are we talking about? Well, we're talking about that the levels of the sugar, the target blood glucose, are 20 to 30% above of our desired optimal level. All right, and we'll get to that in a moment. But I would like to also emphasize problems with hypoglycemia, right? And we're talking about neonatal hypoglycemia. It's not the mama who's getting low sugar. Mama has opposite. She has high sugars, right? Because when this is happening, baby's getting too much of a glucose in the maternal blood, and as a result, baby is responding by the fetal pancreas responding by producing more insulin, and the pancreas will have pancreatic hyperplasia, right? Producing more and more of insulin. As a result, when the baby is delivered, there's no longer high influx of that highly no blood with high elevated sugars in it comes from the mother. But the pancreas doesn't know. It takes time for the pancreas to realize it's been working overtime all the time. And then all of a sudden you stop this delivery of the highly elevated blood glucose in the maternal blood, and babies developing hypoglycemia. On top of that, you can see hyperbilirubinemia. You can have hypocalcemia, hypomagnesemia, polycythemia, respiratory distress, and cardiomyopathy. All right. So a lot of problems come with poorly controlled carbohydrate metabolism, as you can see, right? Because insulin, believe it or not, it's the most potent anabolic hormone in the body. It's not only responsible for bringing glucose into your cells, it's also responsible for bringing amino acid in the cells. It's also responsible for bringing electrolytes into the cells, like potassium. That's why, how do we treat hyperkalemia? Well, there are different ways you can treat hyperkalemia. You can give calcium gluconate, you can give calcium chloride, you can give sodium bicarbonate, you can even give inhaled beta agonists like albuterol. You can give loop diuretics, right? Because loop diuretics lose potassium. Yeah. You can give kioxalate, right? You can give kioxalate. The generic name is sodium polystyrene sulfonate. Well, those are one of the ways to deal with it. There's also patiromer. It's a good drug. Patiromer and zirconium. Those are good drugs that helps to lower potassium in chronic condition, that allows you to still give patients ACE inhibitors, because a known side effect of ACE inhibitors is increasing your potassium levels, and so is ARBs, right? But there is another one, a nice, not tricky, straightforward way of controlling your potassium is giving insulin. You're giving insulin intravenously, and then you help to bring the potassium into the cells. Yeah. You do have to keep in mind, you would have to give it along with D50, right? Because you don't want to drop the sugars, because it will bring the sugars into the potassium into the cell, but you also want to make sure you don't make patient hypoglycemic. because hypoglycemia is a serious complication. Hypoglycemia can affect the brain. Brain is very sensitive to hypoglycemia. All right, so let's continue. And I'm sure it's straightforward why babies develop microsomia, right? Because they have high levels of insulin, and everything comes with that, right? The insulin, as I mentioned before, it's strong anabolic hormone, and it's gonna create a bigger baby, muscular baby. But on top of that, you have lots of complications that come with that. Okay, and there are some long-term consequences. It is known that is a strong marker, that GDM is a strong marker for maternal development of type 2 diabetes mellitus. And that eventually you will have your diabetes-related vascular diseases. It's so severe that according to Conrad Fisher's Master Board USMLE Step 2 6 edition, that it is 4 to 10 times more likely to develop type 2 diabetes mellitus later in life. And according to Robbins and Cotran, it's mentioned that even gestational diabetes mellitus will resolve spontaneously. Majority of affected women will develop overt diabetes. All right. And on top of that, the offspring is at a high risk of developing obesity. And they might have diabetes themselves eventually. And there's an interesting information that it's also might take it seriously, is that the poorly controlled maternal diabetes during pregnancy may impact neurodevelopmental outcome. All right, so you have to think about it and be very serious about such problems as gestational diabetes. They do say that, however, evidence is circumstantial and of poor quality. And I did put it in a fine print because even though this circumstantial, you don't want to risk a well-being of a developing baby in that result. Because let's think critically and logically. If baby's having if the neonate has a hypoglycemia, that there is a chance that there will be damage to some of the neurons, hence it can affect the cognitive abilities of that infant, right? Because as I mentioned, that your neurons are quite sensitive to low levels of carbohydrates. So how do we manage it? Well, we manage it as you probably close to what you would do with a regular pregnant woman. You want to keep the fasting blood glucose less than 95, and you want to have the 1 hour postprandial blood glucose concentration to be less than 140, and 2 hour postprandial glucose concentration to be less than 120. Okay. And I mentioned prior, so there are no standard criteria for describing suboptimal versus poor glucose control, but generally the suboptimal is considered to be 20 or 30% above the normal. So if you're talking about fasting blood glucose, then suboptimal level will be 120, right? So you have to be very careful when managing gestational diabetes, and got to be aggressive with managing gestational diabetes in pregnant women. Okay, let's just reinforce our knowledge. Yes, we do screen women at 24 to 28 weeks of gestation. Okay. And you will counsel them about monitoring their blood glucose. You can consult diabetologist, nutritionist. Okay. It is important. You can start there. But if you can't control that with regular basic corrections, you have to bring some help of insulin and oral anti-hyperglycemic if needed. So if you have uncomplicated pregnancy, good glucose control on nutritional therapy alone, then you just like any pregnant woman, you will do ultrasound to estimate fetal weight between 36 and 39 weeks. And then from there, you just decide, is a baby more than 4.5 kilos or is it less than 4.5 kilos? If it's less than 4.5 kilos, then we can try to deliver the baby vaginally if there are no other complications, right? And that would be a course of action. If baby is larger than 4.5 kilos, then we have to suggest, depending on the circumstances, size of a pelvis and other things, that you will suggest cesarean delivery, right, at 39 weeks. If you have uncomplicated pregnancy and suboptimal glucose control, right, we said above 20 to 30% of our desired level, and patients being on insulin or oral anti-hyperglycemic drugs, then on top of our regular ultrasound at 36 and 39 weeks, we will do additional screening and monitoring at 32 weeks gestation. We can do a non-stress test, and we can do, along with that, we'll do fetal Doppler and fetal ultrasound. And fetal ultrasound will allow us to determine what's the amniotic fluid index, right? It's just additional precautions. We want to look into polyhydramnios and other issues that associated with it. And then after that, we go back to a standard ultrasound closer to the delivery at 36 and 39 weeks to evaluate where we stand. And again, we're checking for the weight. We want to make sure the baby is not greater than 4.5 kilos. And that's pretty much it. There are some differences in terms of when would you do induction in a pregnant woman whose baby is below 4.5 kilos. As you can see, we can wait up to 39 to 41 weeks if in optimal control, and suboptimal less than 40, then we have to suggest induction at 39 if it's at 39 weeks. However, if glycemic control is suboptimal, then we have to do at 37 to 38 weeks plus 6 days. All right. So you can just go over this chart and let it sink in, get a better understanding. Okay. I'm not going to chew it in for you. All right. And what's the postpartum management? Well, there are good news, there are bad news. All right. Well, good news is that women with gestational diabetes should be able to resume a normal diet postpartum, meaning after delivery. Her hyperglycemic effects of placental hormones will dissipate rapidly. And why? Well, as we mentioned, the human placental lactogen that among progesterone, those hormones that producing this hormonal milieu, they've been delivered. So is the baby. So you're delivering the baby and you're getting placenta. You no longer have human placental lactogen. There you go. And pretty rapidly, some even immediately get their sugars under control. Some takes a little longer, but good news is most of cases, the sugars will go to normal levels almost immediately. Side note, what are the signs of delivery of placenta? Ding, 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 ding. You can pause the video. All right, I'm not gonna waste this time, so I'm just gonna give you an answer. And I'm sure most of you already know that the signs of delivery of placenta is lengthening of the umbilical cord. All right, because the cord, after baby has been delivered, you cut the cord, you put a clamp, and you're holding and you're rolling it. All right, rolling, and then all of a sudden it becomes longer after you already rolled on a forceps, on a hemostat. And you're like, uh-oh, it's getting longer. That's one sign, right? It means it's been there, it's disconnected, and it's moving longer. And then thing you can have a gush of blood, second sign, gush of blood. And the uterus becomes globular, rigid, right? Lengthening of the umbilical cord, gush of blood, and uterus becomes globular. Okay. Breastfeeding. It should be encouraged since it benefits both mother and the child. And, mother is producing more milk. It improves your maternal glucose, straightforward. It's not a rocket science. You kind of wasting excess glucose levels and putting it in the milk. All right. Okay. So, and as mentioned, high lactation and longer duration were inversely associated with the risk, independent of weight loss or after adjusting for risk factors for type 2 diabetes. Whoa. Can we say it easier? Yes, I can say it easier. Meaning, the longer you breastfeed the baby, and more intensely you feed, the less likely you will develop diabetes mellitus type 2. Remember, because a lot of women, majority of those women with gestational diabetes mellitus will develop real diabetes later in life. But those who put extra effort into breastfeeding their babies and benefiting the newborn, they will have less likelihood of developing this type 2 diabetes. Think of it as an exercise, as weight loss pills that some women take. It's like you have this natural weight loss machine in your body that helps you lose these calories by feeding your baby. Producing oxytocin makes you feel happy and benefiting your baby. Whoa, that's wonderful. All right. Okay. Contraception. Well, you will consult pregnant women, postpartum after the delivery. You will consult them about contraception. You don't want to, because there is a myth that supposedly as long as you're lactating and breastfeeding the baby, that's your natural birth control pill. Nah. Women are very fertile, especially within the first 6 weeks postpartum. All right, that's why it's even recommended by obstetricians to use abstinence during those periods of time. Okay, because the last thing you just delivered the baby. It's a stressful situation. It's a lot of workload to deliver, take care of the baby, and then you become pregnant again. Well, on top of that, on top of everything. So, you know, you want to give at least 3 years. A study says you want to give at least 3 years uh, between the babies to allow mother to recuperate. Okay. That way you will have a healthy offspring along the way. Benefits the mother and the baby. Okay. Screening for overt diabetes. Here it comes, all right? So since women with gestational diabetes may have previously unrecognized type 2 diabetes mellitus, Endocrine Society recommends to check the glucose levels for 24 to 72 hours after delivery. Just to make sure that hyperglycemia is not ongoing. And they have two numbers they're looking for. Is it greater than 126? That's the fasting level. Or if you have postprandial glucose that is greater than 200, then you have, or why either greater than 126 or greater than 200 for postprandial, then you have to treat the woman for hyperglycemia. Okay, how do you treat them? Well, you can start with diet and exercise, weight reduction, medication. Okay, and you have to look into the whole big picture. It's not one one pill fits all criteria kind of thing. All right. And we spoke about diabetologists in that regard. So if women's fasting level is below 126, then after delivery, right, you can do then in that regard, like, oh no, you're a green light. No, you're not a green light yet. We still have to check again. All right, and you're gonna do the 75-gram oral glucose tolerance test, which is gonna be done within 4 to 12 weeks postpartum. Okay. Women with normal glucose tolerance test, they still consult about, what are they consult about? That the majority of women with gestational diabetes mellitus will develop it. So what are you going to tell them? You're going to encourage them to breastfeed the baby. You will encourage them to exercise, having a healthy lifestyle, right? Normal things that we recommend to any human being. Okay. And last but not least, you will screen them for postpartum depression. Okay. You will screen everybody, but you will be extra careful and observant of possible signs of postpartum depression, because women who had gestational diabetes have a higher chance of developing postpartum depression when compared to regular pregnancies. Okay. And these are my references. Okay. I did dive into up-to-date. I also am very grateful to Dr. Conrad Fisher. It's been my motivation for many years of becoming a physician, and he's brilliant. I have to say that. Has multiple study materials, but I really benefit his book from his book, Master the Boards, Step to CK. Great book. We also used Kaplan Medical. They have pretty nice some deep bits of the obstetrics and gynecology, just like a brief overview. And Robinson Cotran is huge. All right. Robinson Cotran, pathologic basis of disease, 10th edition. Great book. It's a nice film. It's a nicely written, it's proper English. Like reading is a Tolstoy novel. You're not really studying medicine. You're reading the Tolstoy novel. And of course, Edward Golian, Dr. Golian, the legend, who has rapid review pathology. Yeah, it's on my shelf over there. That's probably it for now. In the next topic, I will discuss mitral valve prolapse implications in pregnant women. I would appreciate if you subscribe, leave the comment below, give me your feedback, give me your honest feedback. If I was too explanatory in terms of going into the aspects of gestational diabetes mellitus. And you have to understand, these lectures are made for not just students becoming physicians, but also to nurses, for a general population, to get a better understanding of what gestational diabetes mellitus is. Okay, and listen, if I'm too explanatory in terms of certain things, use it as a good example that you can bring to your patients. Okay, and I'm sure you will benefit from it as well. Your patients will. Okay, all right, well, thank you for watching. Stay tuned until our next editions. Take care.